Dr. Girish to go to the podium, please.
You are ready? Yeah. I think, start the presentation.
Good evening, everybody. At the outset, I would like to thank committee and team of Southern Chapter ISN South Zone for this opportunity, recognition and award. It's been a real privilege to accept this award on behalf of my team members who I'm going to acknowledge in detail towards the end of the talk. So without any further delays, I would like to start off the discussion about our study, which is basically based on therapeutic use of ultrasound and its waves across dialyzer in an external fashion, and to study the impact of it on the clearance of the dialyzer. So it's a standard overview which I'm going to present. So to start with the background, our study and this project basically revolves around these three aspects: dialysis adequacy, dialysis membrane science, which is a less explored topic, and then therapeutic use of ultrasound in nephrology. So as the earlier speaker, Dr. Sharma, alluded to, inadequate dialysis is a major problem, and there are a number of predisposing factors to it, which I have conveniently divided into three zones. And a lot of research has gone in to try and improve the adequacy of dialysis, because some of the studies do show that it can impact morbidity and mortality. And our area of focus was on this particular aspect, membrane science, the dialysis membrane science. So we all have seen this diagram before. Dialysis is a process of diffusion across the semi-permeable membranes. But what is relevant to this study, and what I want to draw your attention to this, is the concept of membrane clogging. So as the blood passes through the dialyzer, we see that the blood constituents and the proteins, they clog and block the pores to start with, and the hydrophobic proteins gets absorbed onto the membrane and starts forming this layer called the CP layer, or the concentration polarization layer. If you allow it to continue further, then it sort of settles down into what is called as a fouling layer. To put it in simple terms, CP layer is like acute tubular necrosis in acute kidney injury, and membrane fouling is like CKD. So if left unattended to, can lead on to irreversible membrane damage. And the principle of ultrasound is conversion of electrical into mechanical energy through these piezoelectric crystals. So the concept is simple. You have a power source and then a transducer, and then you deliver these pulsatile waves in the form of compression and rarefaction. And we all know that there are a number of therapeutic applications for this ultrasound. So just to highlight a few of them, it's used in transcutaneous drug deliveries in areas like lithotripsy, dentistry, eye surgery, body contouring, and in some aspects to dislodge the blood clots. So the aim of our study was to study the impact of ultrasonic waves on clearance of the dialyzer. We all know about KT over V. K is the dialyzer clearance, which is essentially the urea clearance, and KT over V is a measure of adequacy. So the objectives of our study was to see the effect of intradialytic clogging on clearance, and see the effect of ultrasonic waves in reducing this clogging phenomenon, and obviously keeping in mind the safety of these waves whilst doing an in vivo study, because that has never been done before. So these are the standard gadgets we have used in the study. So all our study patients were allocated these OCM activated Fresenius machines, model number 4008S, and all this came with inbuilt TMON software, through which we were able to extract the data, and the machine parameters, the blood flow, dialysate flow, and the dialysate composition was kept static to avoid any variations or external factors influencing it. So the dialyzer we used in all of our patients was single-use low-flux Fresenius Helixon FX8 with a surface area of 1.4 square meters. And what is more relevant is their urea clearance had an average of around 190 mils per minute. So this is the ultrasonic device, the prototype device, which was designed by Nikhil, the director of Sidine Solutions. And this is how it fits in. This is the control system, and this is the ultrasonic transducer, ultrasonic transducer that fits around the dialyzer. So we used ultrasonic waves between 200 kilohertz to 3 megahertz. On the left side, you can see that this is the therapeutic dose of ultrasound we use for various procedures which I mentioned, and this is the diagnostic range. So we used somewhere in between to have that comfort of safety. And I'll show you a small video as to how this transducer fits in. So it's completely external, and we use a small amount of transducer gel. There is no point of contact with any body fluids or any substance, and it is quite safe because we have this control system which is placed well away from the patient, and the mechanism by which it prevents the CP layer formation or dislodges is something similar to what we hypothesized here. So the development of this device started in 2018. Its inception was it took almost 4 years for the design to be fixed, and then for this prototype module to be released. So it was essentially funded by a couple of government agencies, the BIRAC and the startup Karnataka. So it went through test of times from bench to bedside. First it was bench-side testing, followed by in vitro testing without patients, then subsequently in vivo testing on the patient, which is what the data I am going to present on. So we got all the necessary approvals, including CTRI registration and the device approvals. So we took informed consent of patients in their own languages, and we gave them, it was quite elaborative consenting process. We gave them the forms, allowed some time to discuss with their relatives, and then come back to us. So talking about the methodology, this was carried out in a 36-bedded dialysis unit, isolated dialysis unit, which performs about 2,500 dialysis sessions. It was a pilot project, prospective, non-randomized, single-blinded, because patient wasn't aware whether the ultrasonic waves were on or off. Because subsequently we analyzed their quality of life questionnaire, which I think it's an ongoing project. So, and then it was a crossover. So each patient acted as his or her own control during the 4-hour session. And we had about 15 patients. And the way we applied these ultrasonic waves was to cover a total of 30% of the time duration. That's roughly about 70 minutes in an intermittent way, 5 minutes on and then 10 minutes off. The inclusion criteria was essentially the patient had to be stable, 3 times a week dialysis with a fistula, 18 to 65 years, and any unstable patients, those with acute kidney injury, dialysis catheters, we have excluded. And this is actually a pictorial representation of the clearance values. You can see that at the beginning of the session, the dialyzer clearance is well maintained, but as the time progresses, there is a drop in the dialyzer clearance. And this is probably attributed to the clogging phenomenon. And the principles of OCM works on indirect measurement of urea clearance through ionic dialysins. It measures the movement of the sodium, the inlet and the outlet conductivity, and hence we arrive at the urea clearance. So each patient had basically a week where there was no ultrasound, followed by a week where they received ultrasound therapy, preferably not during the long gap weekend, but during the mid-week or the end of week sessions. And at all points we were having safety checks. So we collected data on numerous parameters through these forms, and we took help of a professional statistician along with the relevant statistical analysis to try and calculate our results. So these were the baseline characteristics. I have just abbreviated the baseline characteristics. Most of them were males at around 12 and females were 3. Mean age was about 46 years and all of them had fistulas, and of note is none of them had any significant hospitalization episodes in the last 1 year. And the only thing that can explain this phenomena of reduction in clearance values as the dialysis session progresses is the membrane clogging, which I described in the earlier slides. And when we analyzed the results, we found that those regular sessions without using any ultrasound, in some patients, the reduction in the clearance of the dialyzer was as high as 28%. Whereas if you look at the ultrasound sessions, the reduction was far, far lesser. So if you look at the mean reduction, it was 12.6% in our regular session arm versus mean reduction of 4.4% in the ultrasound session arm. So this is the graphical representation. You can see that each time when we are using an ultrasound, you can see that the clearance doesn't drop. Probably the membrane clogging is prevented, and this very nicely can be depicted on this bar chart. And when we did statistical analysis, we found a significant statistical difference. So this was statistically significant. So the next question was, how reliable is OCM? So for that we analyzed samples, lab value samples for 5 patients and compared with the OCM. So we calculated the URRs and the KT over Vs, and we found that every time there was a higher clearance, higher K value, the KT over V was appropriately higher even in the lab values. This has been done in many studies before, that the OCM compares well with that of KT over V, but we wanted to ensure that our machines and our project were up to the same standards. One pivotal thing is the safety of this device. Throughout our process, we have been extra cautious to monitor the safety, and we have basically had no significant safety alarms during the study period. Constantly there was a doctor present during the study sessions to ensure the safety of the patient. And to be extra cautious, what we did was we took the dialyzers and then put it on the reprocessing machine, checked the pressure tests, and we found that there was nothing, no membrane breakdown, no problems found. So these were all these safety parameters we checked, their serum LDH values, albumin, hemoglobin, and a lot of other relevant parameters, and absolutely there was no statistical difference at all. So it was quite a safe process is what we concluded. The limitations of our study, it's sort of a small cohort pilot study. It's not randomized, and it was probably the durations, retrospectively thinking, I think we have used a shorter span of ultrasound waves compared to what we could have used, and we have restricted ourselves to just use of ultrasound on helixon membranes only. So to conclude, this is the first of its kind in vivo study as per our knowledge, which has been performed when the patient is actively undergoing dialysis, and it clearly showed that significant membrane clogging occurs during each dialysis session, as evidenced by proportional reduction in the dialyzer clearance or the K value. And use of ultrasonic waves retards this drop in clearance, and probably, we are not sure yet, probably may increase dialysis adequacy if you apply it in controlled and ideal circumstances. And definitely safety of these ultrasonic waves is proven beyond doubt in our study. So going forward, we look to expand the study on a bigger cohort, look at increasing the dose and duration of these ultrasonic therapy, and also try and use it on other membranes, low flux, high flux, etc. However, just of note, we started this ultrasonic therapy on reuse, because in most of our units we have reuse policy. But then we found very variable results, especially after the second or third reuse, because their starting clearance values are totally abnormal. So we look forward to suggestions and ideas before proceeding any further with this. And adequacy of dialysis, it's too early to comment about adequacy of dialysis because what we found was just the clearance. Maybe the adequacy, if we had applied it for a longer period of time, it would have been different. We don't know. It's a very short span study done over a period of 4 months. And I think in future we also look to analyze what is its impact on middle and large molecules effect by using this therapy. In a country like ours, I think such innovations which give cost-effective solutions are need of the hour. And I would like to acknowledge my team who have been very instrumental in delivering this project. So Dr. Limesh from Narayana Hridayalaya and Dr. Shashank and Dr. Savita and Mr. Nikhil Das, who is the director of and a chemical engineer who is here from Sidine Solutions. So the brainchild between for this project is Limesh and Nikhil. And this is our KMYF staff who have been very instrumental and helpful in achieving this results. Thank you.
A well-deserved award for you, Dr. Girish, for a novel way of treating dialyzer. But one or two small things. You mentioned the methods, that it is a single-use dialyzer. So you are using for reuse or single use. Second, what about the anticoagulation? Has it got any effect when you use the ultrasonic device?
Sorry, your second question was not audible. Can you please repeat it?
First one was whether it is reused or it is single-use dialyzer, because most of the centers are now switching on to single-use. Second thing is, what is the anticoagulation, that is heparin, that you give, any impact of that on the effectiveness of your treatment?
So the answer to the first question is, we started this project using on reuse dialyzers, and we found that the values were all over the place. We could not put anything, maybe it would not make any sense. So we decided to stick to single-use dialyzers, and that was more predictable prevention of drop in clearance values. The second question is that we use standard heparin in our unit, and it was all standard dose. So the analysis so far, we have not found any untoward effect of anticoagulation on this results, sir.
What stage of dialysis you think the clogging was happening?
I think it starts off very early, probably in the after the first hour. Because if you look at all the OCMs, in the first hour,
So you applied these ultrasonic waves after the first hour?
No. We start applying in the first 30 minutes. Start with the first 30 minutes. First start without the ultrasonic therapy. Then after 15
Then
minutes.
anything with patient characteristics about their hemoglobin, albumin, was there any effect on that?
Absolutely none. So which is why for all the 15 patients throughout their session on a weekly basis, we monitored all the parameters through a NABH accredited lab. And it was even statistically analyzed, absolutely no difference.
Very interesting and very innovative thinking. And if it gets validated, I think all the dialysis machines will henceforth come with such attachments to the machines.
Why not cover the complete circumference of the power fiber?
That's a very good question. I think our chemical engineer might be able to answer, but I think initially we wanted to go slow. The idea was to ensure the safety. So probably going ahead, this is just a prototype device, going ahead we will take these valuable suggestions into account and modify these designs, and hopefully we'll be able to take it forwards.
And also I was thinking about how uniformly these waves are being delivered.
No, I think that's a very good question. So that is something we have not thought about, and I mean, I don't know how to measure the uniformity of the wave, but as Dr. Prakash rightly said, maybe we will have to think of covering the entire dialyzer and analyzing our data. And we were also thinking of some ways to post-mortem our dialyzer after the study, and we have not got any bright ideas to do so.
In non-renal conditions where you have mentioned that it was used, how is the impact, how it was working?
In the, sorry sir?
In non-renal conditions where like dentistry and lithotripsy and all,
I think it's a standard policy to use there. I mean, there is enough data, like for in lithotripsy and stuff, for specific
how it works.
conditions. It works with lower frequency and it is reasonable. So the studies show that they've all been already in use.
Open to audience.
Congratulations, Girish. Excellent idea and pilot study. You showed about the data pre and post dialysis, but that was kind of very fast. Was there any rise in potassium at the end of the treatment in ultrasound? Because LDH, although statistically not significant, LDH was slightly higher in the ultrasound group. Was potassium any different? And also, being 15 patients, you may not find statistical difference. When you applied larger number of patients, that will be one concern, obviously, that is one thing. And secondly, as far as covering the entire surface may not be necessary because it's like CT scan, you know, as long as you're covering the cross section, that may be sufficient. Again, I don't know. I mean, that kind of, you said post-mortem of the dialyzer may help you whether the energy is focused along the entire surface.
Yes, sir. There was no difference in the potassium values. As you said, it's a smaller cohort, and which is why we tried to analyze not only LDH, all the parameters of hemolysis, like the bilirubins and stuff, and we didn't find anything because that is something we were really worried about as well.
Yeah, first of all, congratulations, bringing in something new in the dialysis after almost 5 decades. So, most important, few things about. Did you measure the residual bundle volume after the procedure and as per the standard literature of your dialyzer? Was there any change in the bundle volume at the end of the dialysis?
So
did you calculate that?
We did that by putting the dialyzer on the reprocessing machine, and surprisingly, we didn't find any change in the bundle volume, and it passed the pressure tests. Because it was single use, we just obviously
in patients in dialyzer who have not been subjected to this particular ultrasound, what is the bundle volume in those dialyzers versus bundle volume in the procedures in which the ultrasound therapy was used? And the other important question, does the ultrasound wave traverse the casing of the dialyzer, and does it still effective in the
So the answer to the first question was we didn't find any difference between the regular sessions and the ultrasound sessions. The bundle volume was still retained.
No. What I'm saying is you are hypothesizing that over a period of time the bundle volume probably goes down and the clearance slowly goes down over 4 hours period. So, and you said that with this ultrasound your clearance will remain the same throughout the 4-hour session. So then does the bundle volume change in the sessions in which there was no ultrasound therapy like any other regular patient versus in the sessions in which you have given this ultrasound therapy?
So we have that data, but as far as we have not analyzed it completely, but as far as we are aware, there is no major difference. There's no major, there was a reduction.
Difference means
in between the...
Do you mean to say that the bundle volume was equal in patients?
Equal.
Then why did the clearance go down then?
Those are the unanswered questions, sir.
And then what about, do you think theoretically this ultrasound waves traverse and have effect on the vascular bundles which are inside, and then with that thickness and those volumes, does it is effective even across this?
That's a very valid point, but then I don't understand then why the reduction, in retardation in the drop in clearance occurred. So which is where...
Yeah. May I make a suggestion? I think, sir, what they're proposing is not the occlusion of the entire capillary, but just the pores at a micro level occlusion that may not necessarily translate to bundle volume change at the end of single dialysis. Maybe if this is applied over 10 dialysis, maybe you may see a difference in the bundle volume between the two arms of the
And hence, that is the reason maybe we didn't see much difference in the KT over V and
Professor Kasi Vishweshwaran.
Yeah, interesting concept. The fouling occurs in the RO membranes as well. And when fouling occurs, in the early stages of fouling, what we do is remove the RO membrane and then give a mechanical shock, not ultrasound shock, mechanical shock by just putting it in the and the fouling considerably disappears. Similarly, in a hemodialysis situation, even if you give a mechanical tapping of the dialysis cartridge, does the fouling decrease? That is one thing we have to consider, because after all, this is only agitation of the inner lining of the your hollow fiber. The second thing I want to know is, between this ultrasound, normally if you good dialysis, you get a KT by V, or you can get a urea reduction by nearly 70%. Does this procedure increases from 70 to 80% or 70 to 75%? I mean, to what extent does it improve the urea reduction ratio?
The answer to the first question is that we don't know. We don't have a definitive answer at this point, whether, until we examine the process microscopically, whether it's going to dislodge, by tapping, I don't know any studies where by mechanical movements the fouling layer is displaced. Correct me if I'm wrong, but as far as I'm aware, there is no data on that. Secondly, I think because it was applied in only shorter duration and one session or so, it may be too early to see a difference in the adequacy. And already we have a fairly decent adequacy, as you rightly said. Maybe it is in the long term, if you use it over a period of 3 months or so, it will be interesting to see how it translates into the clinical clearance and adequacy.
Shivkumar.
So I congratulate for the excellent work. There are two questions that I need to know. One is, by electron microscopic studies, scanning electron microscopic studies on the membrane of the hollow fiber, even on regular dialysis, they have brought out a lot of morphological changes in the form of the surface becoming rough. So even such a incomprehensible injury of the shear flow of the blood is capable of producing a minor changes on the electron microscopy. I think probably this agitation of the membrane needs to be studied in vitro as far as what's happening to the membrane. That's one, because the microemboli are going to be dislodged, and what is the effect of that goes into the body. Because when you see the effect of in ESWL, when the ultrasound waves pass through, it is definitely going to produce damage in the transit. And that has been shown to induce antiglomerular basement membrane antibody disease. So it means it's not simple. The second aspect is, if you take the interface of medical law and ethics, this is a human experiment, and has the approvals been taken from the ICMR, and has legalities have been studied into this? Because unless for a human experiment, unless you do phase 1, phase 2, phase 3, it's not possible to accept these things. Thank you.
So we've got all the necessary approvals, including the ICMR and the registration to CTRA, sir. So which is why I think I've emphasized the point about safety. And again, a lot of electron microscopic stuff that goes behind the membrane, I think that is definitely worth studying. So this probably lays a path for us to work on this in future. Because we were just discussing with few companies to try and see how we can try and tease this out microscopically and take this forward.
Thank you.
Any, Dr. Manisha?
Yeah, congratulations, Dr. Girish. So I just wanted to know, there was some doubt what Dr. Girish sir was telling, that whether the ultrasonic waves would, they'll traverse the casing. So would the same effect be obtained if we attach a vibrator to the dialyzer? Something vibrating the dialyzer?
Probably, that's a very tricky question, but well, the answer is I don't know, because that is where we have to probably see. But the vibrations are more likely to dislodge microemboli is what my common sense tells. But again, only testing will tell us. But we have not done this in vitro, but that's certainly something we will probably start doing it in bench side before we plan to go any further.
Thank you, sir. Thank you.
Thank you.
Thanks, Dr. Girish. We appreciate the innovative way you thought about this. Many questions will be there. I know you will not have the answers for many of them, like even the physical vibrations, whether it can declog, and what should be the dose, what frequency has to be, what is the optimum frequency, etc., and what damage it may cause on the membrane. All this needs to be studied, but we really appreciate for the thought that you have had that something like this can be done. On behalf of the Southern chapter, I would like to congratulate you for having won this award and for the excellent presentation. Thank you.
Well deserved award, Dr. Girish. Thank you.
Thank you, sir. May I request the chairperson to, Dr. Girish, please stay back. May I request the chairperson to kindly honor Dr. Girish. May I request Dr. Yuvaraja to kindly hand over mementos to the chairpersons.